Hi everyone, I'm Chris. My last name's pronounced Pizatowski. I know it's a lot of letters on there. I'm a ambulatory care clinical pharmacy specialist with the University of Florida. I work in ambulatory care out in family medicine. I've got a couple clinics under my belt, working as a sole pharmacist, do some telemedicine to some other clinics. But today we're going to be talking about a program called Chronic Care Management. It's essentially a Medicare billing program meant for patients who have a number of chronic disease states and how pharmacists can get involved with that. So this is going to be a short presentation, probably just anywhere from 15 to 30 minutes of us talking to you here. And then we're going to open it up for more of a roundtable question and answer type scenario. I'm just going to ask that you hold questions until the end. We'll ask that you put them in the chat, and we'll do our best to read through them and try to answer as many as possible. At the end of these slides, there is going to be the information for how to claim the CE credit. So, like I said, we'll get started here. I'm Chris Pizatowski. My co-hosts here are Amanda Martinez, Nishi Sadkar, I hope I'm pronouncing that correct, and Delilah Blanco. So, disclosure, none of us have any financial or institutional disclosures relevant to this discussion at this time. And tonight we're going to talk about a couple things. So, what the intent and philosophy of chronic care management, otherwise known as CCM, is. I'm going to go over the required workflow components for that program. We'll talk about the billing and reimbursement aspects of such. And then we're going to discuss the history and perspectives of kind of various CCM programs, which is going to come mostly through that roundtable part. So what is chronic care management? So got the actual quotations here, and that link here is the booklet to the CMS website. That is the best comprehensive information. It's about a little 15-page just fact sheet and guide sheet for you. Basically, everything that we have to talk about today is coming from that. But chronic care management services are generally non-face-to-face services provided to Medicare beneficiaries who have multiple, which means at least two, chronic conditions expected to last at least 12 months or until the death of the patient. Now, Medicare is specified in here. There are private insurance programs that will accept chronic care management services, but we're going to be talking about Medicare since this is where it was basically birthed from. So like I said, that link there that's from September of 2022, but it is what's considered basically the fact and guidance sheet. So philosophy and intent of chronic care management. So two things here is to provide continuous high quality healthcare and reduce the burden on the healthcare system via clinic visits and hospitalizations. So what we talked about how it has to have two chronic conditions. When we think of chronic conditions, we're talking the bread and butter things. So high blood pressure, hypertension, diabetes, dyslipidemia. There's a list of roughly 20 or so actual conditions that are specified for this, but realistically, if it's a chronic condition and meets these criteria of lasting until death of the patient, then you could ostensibly do them. The intent is to do these monthly. You're going to be, whoever is the providing healthcare provider is going to meet with the patients monthly. Doesn't have to be face to face, can be over the phone, and doesn't actually have to be involving talking to the patient, even though realistically you should. But it's a certain time frame that we'll go over later that you have to spend per month working on the patient. This is thought to help reduce admissions to the hospital. It's to increase contact time with the patients because you are checking on their case at least once monthly instead of however often they'd be able to get into the clinic. And thereby it's going to reduce cost from insurance payers, costs from just hospitalizations and preventing adverse health outcomes. So who can provide chronic care management? So the list until it gets to pharmacist is those who can technically bill for it. Now I put pharmacist in asterisk because we can provide chronic care management, but we don't actually bill. We're not just in the state of Florida allowed to do so, but we can do so under general supervision with the provider that is managing the condition. So we will just document our time and I'll go over how we do so. And eventually the providing healthcare practitioner basically signs off on the visits and the management protocol. This list here, again, is that bullet point list of those conditions that qualify for chronic care management. It is not an exhaustive list, but this is the most common chronic disease states that we run into. So you can see a lot of just the usual things that pharmacists are involved with. So hypertension, diabetes, heart failure, AFib, hyperlipidemia, asthma, COPD, and then a couple other ones on here that we traditionally wouldn't be involved with, like hip or pelvic fracture, not necessarily Alzheimer's disease, depending on where you work, or cancer. So it's a wide-ranging list, and you can make a case for most chronic conditions to be included in this. So when we talk about how it's actually done, there are a number of specified items in the booklet to say, here's what you need to do in order to qualify for reimbursement, which is what it all comes down to. So there has to be an initiating visit. It does not need to be specific for chronic care management. So this is when the patient sees whoever is their primary care provider or the one who's going to be the billing provider for this service, and they have to delineate in there that, hey, yes, this patient is going to join a chronic care management program. Chronic care management can only be billed by one provider per month for a specific patient, so you need to make sure you're the only one doing it for this person. And you just need to kind of delineate in that visit what conditions will be managed, who's going to be managing it, just the general background information. There has to be a patient consent because how this is billed on the patient end is it's kind of like a subscription service. Medicare, when I last checked, was about $8 a month to the patient. Some insurance plans will actually be more. Some will cover it. Like Medicaid actually offers some coverage to that cost. But if you're going to bill the patient separately from what they would traditionally be seeing in their healthcare office, then you need to make them aware of such. That patient consent also has some specific language saying, the patient has the right to withdraw at any time, just providing written consent or written denial of service, and the chronic care management billing will be stopped at the end of that next month. You have to then record patient health information, which should be a given. If you're taking care of a patient, you should be writing down, hey, here's what we're doing, what's going on with them, how we're taking care of them, what labs we're ordering, who we're talking to, etc. A care plan must be documented for that patient. So they need to have a paper or however you format it to say, these are the conditions that are being managed. This is the goals of management for those conditions. So for instance, hypertension, goal blood pressure less than 130/80. Diabetes, goal A1C less than 7%. What medications they're taking, any healthcare providers that you're liaising with, who all is involved with the plan, so they know who they can contact, because it's not just pharmacists. There are many programs where it's a team-based effort, where instead of just a pharmacist providing this service for a physician, it can be social work, nurses, health coaches, a lot of people getting involved. You have to be managing comprehensive care, care transitions, other care services. Really, you're doing this to take care of the patient on a global effort to make sure they're not coming into the clinic or being hospitalized more frequently. So if you're just doing things in your own little siloed world, that may not be the best for the patient. So you got to be handling everything involved. You also have to have information for the patient for access and continuity of care. So who is the one providing the service? How do they contact you? Technically, they're supposed to be able to contact someone 24/7. In the outpatient world, which many of us exist in, that doesn't happen. The clinics are not open 24/7. So they need to have information for when they need to go to the hospital, or if there's a after-hours service line they can give a call to. And then billing. Billing is the tricky thing here. So with how this works, everyone or the pharmacist, say I'm the one doing this, I have to spend 20 minutes per month working on the patient. And that 20 minutes can be spent via however I delineate. So chart review, ordering medications, liaising with the physician or other care providers to discuss the patient, talking with the patient themselves, either on Zoom or on the phone or via messaging. That does not always happen in one 20-minute spurt. So you may spend 10 minutes here, you may spend 15 minutes there, etc. So billing has to be done in one little encounter, but typically you wait till the end of the month to document all the time you spent and send it in. Depending on your EHR, some make that a lot easier than others do, and depending if you have the billing team at your institution involved, that can make that a little bit easier on the back end of things. So talking about billing, there are a number of codes to use. This is actually missing the initial visit, but again, that's not billed by pharmacists, that is done by the provider. Most often, we are going to be operating under the 99490, which is the non-complex. So that is 20 minutes per month of clinical staff time. Pharmacists count as that clinical staff in qualifying services. The billing practitioner has to provide ongoing oversight. What that comes down to, this is done under general supervision, meaning that a billing provider, such as a physician, is involved. They're not necessarily always seeing the patient, and they do not have to be in the building to do so. So it's not direct supervision, it's under general supervision. Every 20 minutes, you can document that 99490 for that initial 20, and then the 99439 is if you do another 20 minutes. So you can actually bill, you can do more time, you can spend more time with the patient as needed, and you can bill for higher levels of reimbursement. There are the complex CCMs. That is more defined on patients who you're taking care of conditions that place them at a high risk of death. So the time requirements go up. You have to have an initial of 60 minutes, and then any additional block is 30 minutes. I'm going to back up there just for 1 second, just to talk about some things I may have missed here. So for billing, I personally don't like to do so, but if you're talking to administrative services at any of your institutions on, hey, do I want to get this started? They're going to ask you about the money instead of rather the patient care per se. So in today's realm, especially outpatient care, physicians are hard to come by. There's estimated to be like a 6,000 physician shortage by 2030, I think is the data currently, and it's probably worse than that. So with that, everyone trying to go see their doctor is tough. You may not get in for 3 months. You may not get in for 6 months. So imagine there's 25 patients at your practice who you want to do this for. If they were somehow perfectly seeing their physician every 3 months for hypertension and diabetes, that'd be 4 visits a year times 25 is 100. You're looking at, this is reimbursed, I think, at about $43 for every 20 minutes. You're looking in total over the year about $9,000, $750. So with that, that's a lot of clinic time that's taken up for these patients, and that's the reimbursement rate. Now, if you do this monthly for those 25 patients, where you as the pharmacist are taking that off of the physician's clinic time, the physician is still involved. They're still seeing the documentation and signing off for these patients. You actually up the reimbursement by about 25%. So you can be estimated to make about $13,000 off of doing chronic care management for those patients rather than coming into the office for presumably level 3 office visits. So there's a good, monetary side to this thing, but there's also just the better patient care. A lot of times, this is for Medicare patients. They are older patients. Every 3 months may not be enough for them. They may need more of that constant contact to help keep them in line and taking good care of them, preventing them from going to the hospital. If they have any questions that honestly, sometimes trying to call their physician or get messages to their physician can take time, and we're just a little bit more available. I think that's most of what I wanted to talk about. Of course, I am going to be here to answer questions for this. We do this at the University of Florida in a small capacity, but TGH, the people here and from Tampa General, are going to talk more about their program, which is a good bit larger. So I'm going to turn it on over to them. Y'all just let me know when to advance the slides.
Okay, you can advance the slide. And just to introduce myself, my name is Amanda Martinez. I'm one of the pharmacotherapy specialists for Tampa General Hospital. I've been there for over 10 years, and I helped implement our chronic care management services around 2017. So we'll go through our journey, and if you have any questions about how we started everything, if I missed anything that you really wanted to know, of course, we can answer those questions at the end. But we started these services in around 2017, initially as a very small clinic pilot with about 51 patients. And what was key to this pilot being successful is making sure you had all of the key stakeholders. So I know Chris mentioned billing. So we had billing as part of our team. They were one of our stakeholders that was involved in the very beginning and all of the meetings, billing. We had IT, we had our medical director, our clinic administration, lead nurses, myself, and we all kind of had these working meetings about once a week to develop the workflows, delineate responsibilities, how we're going to identify patients, who's going to identify, who's going to enroll, and then how the day-to-day goes each month, who's going to call the patient, what the templates look like for documentation. How do we integrate this in our electronic medical record and make it as easy as possible so it's not so time consuming. So that pilot was successful, and it kind of grew over the years, but we quickly realized that it grew so big that it was a little bit difficult for our clinic nurses to handle on their own. So our clinic nurses were being pulled for annual wellness visits, for other things on the fly. So they couldn't take time to make these chronic care management visits. And sometimes they could take a long time, and patients can be on the phone for quite some time. So we were losing that opportunity to enroll people in chronic care management and keep them engaged. So in 2021, we did partner with a vendor. There's several vendors out there that you can partner with, but the vendor, what we use the vendor for is to really enroll a bunch of patients. So identify the patients that meet criteria, enroll them, explain the program, get their consent, and that we use their LPNs and their nurses to really run the program, and used our pharmacists. So we rapidly expanded the chronic care management program, working with the vendors and kind of aligned our protocols. They had their own protocols. They work with a bunch of other facilities, but they never worked with pharmacists. So we really had to set certain protocols and teach them how pharmacists can be involved and when to involve pharmacists in the chronic care management service. So now, after partnering with that vendor, we have, like I said, rapidly increased our enrollment. So we're up to about 4,000 patients that are enrolled and actively engaged. We really focus on our ACO, value-based care plan. So our ACO, one of the core measures for our ACO and to receive shared savings is to enroll a certain percentage of patients that are under our ACO, enroll them in chronic care management or remote physiologic monitoring. So it was a big key metric. So we really need to enroll these patients because, like Chris mentioned, the whole goal of the program is to save money on healthcare dollars, keep patients out of the hospital. So right now, we've also integrated our remote physiologic monitoring into the chronic care management. All right, next slide. So a key to our success, while we were able to rapidly increase the number of patients in chronic care management and keep patients engaged and really use our pharmacists to the top of their licenses, we really focused on team-based care, where we're using every profession to the top of their license. So nursing, our LPNs that we partnered with the vendors for, and then our pharmacists. So our pharmacists weren't used for, making appointments or closing certain care gaps. Our pharmacists were really used for chronic disease state management and utilizing the collaborative practice agreement to meet certain outcomes. So, hypertension, diabetes are big ones that we get a lot of chronic care management referrals for. And we left like the closing certain or other certain care gaps to our nursing partners that were better equipped instead of using all of our pharmacy time for that. So it really helped with efficiency, like I said, improving quality. So the pharmacists were really able to focus on those patients that were uncontrolled uncontrolled hypertension, uncontrolled diabetes, and improve those patient outcomes. And it led to decreased clinical burnout. So the nurses don't have to reach out to the providers and say, hey, I call this patient, their blood pressure is uncontrolled. Pharmacists can get involved instead of the provider and kind of let them see patients. All right, next slide. Can you guys hear me? Okay, next. So again, this is kind of the layout of the team-based model. So the provider for chronic care management is, of course, the one that we are billing under. They oversee all of the patient care, the care plans, and approve them. The nurses did most of the call cadence. So the once monthly, if the really complex patient, they sometimes would even have to call them once weekly. They were responsible they are responsible for developing that care plan, any care coordination. So if the patients visit specialists that are outside of our system, making sure to get records, things like that. We also taught the nurses to utilize our nursing refill protocol so they can fill those make those refills instead of sending it to the provider or sending it to one of the clinic nurses, that they can go ahead and fill those medications. They address a lot of care gaps, and they also help with appointment scheduling. So like annual wellness visits that need to be done, or if there's acute care issue, like patient complains of urinary tract infection symptoms, they can schedule that patient in for a same-day visit instead of sending that patient to urgent care or to the ED. We also partner with our social workers, so we can refer patients for chronic care management to the social worker, and they help us with certain social determinants of health, some behavioral health issues that maybe are outside of the pharmacist scope. And we really utilize, like I said before, the pharmacists. We utilize them at the top of their license. So for those patients that are uncontrolled, where their disease state's uncontrolled, so we can come in and manage those patients under the collaborative practice. We also do medication reconciliation. So for complex patients that have multiple medications, multiple comorbidities, multiple specialists, and also focus in on medication adherence to improve those measures as well. Next slide. Another key thing besides team-based care is really leveraging your electronic medical record. I remember in the beginning when we were going to pilot this, we were thinking about using an Excel to calculate the minutes that we spent with a patient, which is insane. I was like, there's no way we can scale this program by using an Excel sheet and then manually billing. So we built it in our electronic medical record, where it's a hard stop. You have to put in the minutes. You have to put in where it's complex or non-complex. And for our chronic care management, most of our pharmacy patients, we bill as complex because we are making changes that the provider eventually signs off on. And also a hard stop is the diagnosis, because you have to have that to bill. So any kind of required billing components are hard stops. The billing is all in the background, and it's integrated into our electronic medical system. Enrollment is all built into our electronic medical record as well. So we have flags that pop up that say this patient qualifies. Do you want to enroll the patient? We have reports built that identify patients that qualify as well. And we also have reports that show us who's enrolled, how many minutes we have for that month so far, how many minutes we have remaining before we can build the next code. And then we also have a lot of our documentation is templated, so it's as easy as possible to perform these chronic care management services so that we can scale it on this level and see 4,000 patients. All right, I think that may be the end of the slides. So we'll open it up for questions.
I don't see any questions in the chat, but please, if anybody has any questions, please put them in the chat. I actually have a question for you. Do you have any specific pharmacy referral criteria that the nurses have so they know, okay, this is a patient that has to be sent to a pharmacist? And do you guys have a referral on the back end that you guys manage? And that's how you get the request?
So great question. So we do have a criteria. So for medication reconciliation, we have that they have to have at least 10 chronic meds. And that soon got to be too much, because you can imagine 4,000 Medicare patients, most of them probably have that. So we then had to add a caveat that if they have the 10 chronic medications, that they have some kind of medication issue or question, or the nurse's discretion, like this patient could use a pharmacist. So it wasn't a flat criteria of 10 medications or more. And then for diabetes, A1C greater than 9. For hypertension, just uncontrolled hypertension. So we define that as a blood pressure greater than 140/90. And then we also have hyperlipidemia. But the hyperlipidemia, they have to have clinical ASCVD and then an LDL above 100. But that was all because it was getting too big. So we kind of had to scale it a little bit so that the pharmacist could handle the volume that was coming through. And I think the second part was, so it is an actual referral. So the nurses for chronic care management can put in the referral. Gotcha. And we can refer ourselves as well.
Okay. And do you guys have a template of your schedule? You only see patients 20 minutes, 30 minutes, an hour? Is there different cadences?
So we don't have have like a certain cadence. So we have usually a pharmacist will have set aside time, like a day that they can work on chronic care management patients. That way it's not so scheduled, because you quickly learn. You may think one appointment will take 20 minutes and it takes an hour, and it's actually a really complex patient. So we try not to have it scheduled where you're seeing, this many patients a day for chronic care management, more that you have a day of chronic care management to take care of your patients.
Okay, I think there's a question in the chat. Is there a maximum for office visits patients can have a year?
So with that one, just to make sure, we're talking about office visits, the patient's actually coming in. That can be its own thing, actually seeing their provider, billing under that for real office visits. Technically, there's no maximum, but, has to be medically necessary. Can't just see a patient every other day for blood pressure if you're not actually doing anything about it. For chronic care management, it's just billed monthly. So it's just the total time that you put into them each month. So you bill 12 times a year ostensibly, but the time codes associated with that may vary.
I have another question. I don't see any other questions in the chat. Amanda, does Tampa General use Epic for their EHR?
Yes, we do use Epic, and it has been instrumental to the success of the program, being able to build all of this into it.
Gotcha. Okay, there's a question in the chat. How do you capture the patients? Do you have a person secretary that looks at the hospital discharge patient?
For my side of things, we have some reports built into the analytics team where I can run a report saying, hey, here are the qualifying conditions. Patients have to have at least XYZ, and it'll format it with the patients who do qualify. Also, just leveraging the providers that you work with. They're in clinic, they're the ones seeing these patients. So if they know that you exist to do this chronic care management service and they've seen the outcomes of it, they're more likely to refer to it themselves. That's at least how we're a much smaller scale at UF than Tampa is, but that's how it works on our end. I'm sure Amanda has at 4,000 much more.
So we have several different ways that we can identify patients. So in Epic, we have a report built that will literally identify every patient that may qualify. So if they have 2 chronic conditions, and we've built that in the background, like those CMS chronic conditions, and so we can pull that report, and it can be cumbersome because it will pull tons of patients. We also leverage our outside ACO platform. So that's where we enroll how we enroll a lot of patients is we'll pull a report from that ACO platform and say that identifies patients as high risk. So high risk heart failure, COPD, and hypertension. And we just give that list to our vendor, and they have enrollment specialists that will call patients to see if they want to join the program. So that's one way. And then, like Chris was mentioning, the providers can enroll patients themselves during the visit. They may say, oh, this patient is very complex. They really could benefit from chronic care management. That's one way. During care transitions is another good point. This patient's high risk. They just got out of the hospital. So when we call patients for that transitions of care phone call, we will advertise chronic care management services sometimes then when we think that they would qualify. And then pharmacists can also enroll patients in chronic care management if they're already seeing a patient. Say we're seeing a patient for diabetes. We'd say, hey, this patient, we could enroll them in chronic care management and use that billing instead of the 99211. So we could do that as well.
I have some other questions in the chat. So Catherine asks, is Epic the vendor use? So I'm assuming she's talking about like the outside vendor that you guys use.
So the outside vendor that we use, it's not Epic, it's Signal Lamp. So there, like I said in the presentation, there's a ton of different vendors. Signal Lamp is just one, and each vendor provides different services. Some vendors are just strictly enrollment. Some vendors use their own nursing, their own LPNs, things like that. There's some vendors that you can say, hey, I want to do everything. I just want you to do the enrollment. You do the like billing in the background. So it's all based on the contracting and how you work with your vendors. And I will say we had a horrible experience with one vendor, and I kind of left that out on the progression of the program. But we did in the beginning have a vendor that was not very experienced, and we did have to part ways with them. But our new vendor has been much more experienced in chronic care management and how to enroll and how to really integrate nursing into our workflows instead of just their workflows.
Next question I see is from James Rogan on how did you get administration to buy in? On my level, I work at several clinics, so I talk to the medical directors directly, the clinic managers, as well as our administrative staff above them. So really it came down to showing that, this is a program, chronic care management is something that's been allowable for years. So it's easy to show, one, the financial impact of it. The math that I provided earlier, that you can make about 25% more in terms of just revenue dollars. We also got the physicians to buy in because, again, we're taking patients from their already busy schedules. Physicians, at least where I work, they want to see patients who are either more urgent or more complex to actually deal with those issues versus, hey, I see this person every 2 to 3 months for hypertension. That is an easy visit they can offload to clear up time for themselves. So the productivity, at least where I work, the RVU slots, they go to the physicians. So the physicians are getting extra RVUs for just kind of indirectly overseeing us managing their patients, but then they're also able to backfill those slots that they would have had taken up by this patient with another one. So they get more RVUs, the system gets more revenue, and then we're able to show that we're keeping people out of the hospital. We're dealing with a lot more we're just lessening the burden on the healthcare system on the clinic level. It's not a hard conversation, at least in our experience. The hardest conversation is billing and compliance, getting the people whose job it is to audit and protect the system from any sort of lawsuit to be on board, which is its own whole conversation. But from the administrative side, everyone sees the value of, yes, dollars and cents and patient care, and honestly, a really good marriage there.
Yeah, I echo pretty much everything Chris said. It's a really easy sell once you tell them all of the great benefits of chronic care management, and it's reimbursable, right? So I partnered first with one of the medical directors who was really on board and pulled everyone in. And then now it's a must. So our ACO requires it. So you have to have a certain percentage of patients enrolled in this program to meet certain shared savings metrics. So ACOs are seeing the value in it and making it a requirement now that we utilize it.
I do also have a message that I don't think went to the whole chat, asking, does the patient have to come to the clinic or hospital, or can you go to the home? You can do these in a variety of formats. You can actually meet with the patient if you so choose. That does not tend to be the most time efficacious version, but you can call the patient, you can be on Zoom with them, you can message them. There is not an actual requirement to make direct contact with the patient in terms of a conversation, although you absolutely should, because that's just what good patient care is. You shouldn't be leaving voicemails or sending them a message hoping they read it and take care of themselves. But there's no requirement in the actual format of the patient conversation. It just has to be 20 minutes per month working on the patient in some form or fashion.
Yeah, I think Chris kind of alluded to a good point. So it's not just the time that you spend is not just with the patient though. So you can bill for those minutes for care coordination. So requesting records from the cardiologist and reviewing those records and kind of putting those in your system, as a pharmacist, if we were looking at a cardiologist note and say, oh, they started carvedilol and we're updating the med list to include carvedilol, that counts towards chronic care management. So it doesn't always have to be with the patient. So it's part of the care coordination. And then there's some patients that we do see face-to-face just because it seems to be more effective for some patients. So I know it says non-face-to-face, but they do allow for some face-to-face, and just kind of spell out why saw patient face-to-face because they're hard of hearing or, whatever reason that your patient does better with a face-to-face interaction.
And you're not billing, the billing doesn't change for them coming in. So you can't really document an office level visit versus a chronic care management billing for that month. So if they come in, great, you should say why, but more than likely it's going to be telemedicine. I have, what are the requirements for the patients to stay in the program? Again, it's just 2 chronic health conditions expected to last at least 12 months or until death of the patient. So they can withdraw at any time. They just have to, I believe they have to submit a written request, although you can absolutely facilitate that. But yeah, they can just keep going ostensibly forever.
Yeah, and the key is to keep them engaged. If they don't feel like they're getting value from the service, of course, they're going to stop answering the phone and they're going to say they don't want to be involved in this. And honestly, that was the issue we had with the previous vendor years ago, was the patients were not finding value in it. They knew their insurance was being billed, and when they didn't have a pharmacist involved and it was just one of the vendor's nurses or whoever called them, they found no value. And with this new partnership with our vendors, they're much more experienced. They're really into the care plan, the management of the patient, closing care gaps, making sure the patients get what they need, not being a middleman. It really gets hard when the vendor is a middleman. So giving them as much leeway as you can that your system and administration will allow. Like, hey, I need a refill on this. They can refill it instead of, oh, let me try to contact your doctor the same way that you try to contact them and we can't get in touch with them. You really want the patient to be engaged, to feel like they're getting a value from the service, and they'll stick with it.
Let's see, I have for your collaborative practice agreements, are you using the consultant license or CPA certificate or both?
For our collaborative practice agreement, we all of our pharmacists have consultant licenses.
And that is the end of the questions that I see. We do have 20 minutes left in time, so if anybody has any further questions, please keep them coming.
In your experience, I have a question. When you're billing, do you usually bill just the 20 minutes, or do you notice that you're spending more time on certain patients, especially, I guess, Amanda, for you, when you're seeing patients that are getting referred to that might need more medication management?
So most of the time it's over the 20 minutes when pharmacists are involved. And our system, the way we set it up, is so cool. We don't even have to think about it. So we don't have to say, oh, we met this billing criteria. It's all built in our system. We just say, this is how many minutes we spent with the patient. So then we have to think about, pharmacists may spend, let's say, 45 minutes with a patient, but then also their care manager, with the vendor, may spend another 20 minutes with the patient. And then someone in our clinic could also bill for time. They may say that a patient called asking a clinical question. They document 10 minutes spent. So it is a collection of all of the time spent from the staff members. But usually I would say patients that have pharmacy involvement have the higher billing minutes, and then also more complex billing.
I guess another question to follow. Oh, sorry.
I was just going to say, there is also a program called Principal Care Management. So chronic care management is 2 or more conditions. There is some capability to do it for less than that, with just 1 condition. Has its own requirements and everything going on there, but just wanted to mention that too, that it is not always chronic care management. However, what Medicare patient do you know only has 1 chronic condition?
Exactly. Yeah, that's why we never really entertained that billing opportunity, because most of our Medicare patients are 2 or more. It's easier just to stick with that program.
I have a follow-up question. I know there's another question in the chat. So, Chris, when we're doing those add-on billing codes for both the complex and non-complex, is there a limit to how many add-ons you can do for a month?
I don't believe there is, as long as it's all billed under 1 provider. Now, of course, that has to be substantiated, because you are always.
Yeah, we've had patients with hundreds of minutes
Wow, and you guys are able to bill for all those add-ons. So there's not like,
Mhm.
that's good. Okay.
But at the same time, it does really take a team effort, because our system, in Epic, I'm not sure how many people are familiar with Epic. There's 1,000 ways to do one thing. But we use the patient care tab. That's like this mix of a telephone encounter and an actual in-person encounter, so you can attach billing to essentially a telephone encounter. But on the back end, we have a billing compliance officer who kind of stitches together every documentation of, hey, if the pharmacist saw them, or if the pharmacist did them multiple times, we're going to combine all these things into one encounter, so it's just one submitted bill. It's a lot, there's a reason they want this done, is there's so much that you can help a patient with in terms of managing multiple conditions and the whole team aspect involved, that you really have to have your stuff together too. And Epic is, in my opinion, the best EHR to do so. Some other systems like Meditech, for example, will mostly be undoable for this, or it's very tough to do so. So if you have an EHR that allows you to do it, have someone involved who's on the IT side, who knows what they're talking about, how to actually make this stuff work for you.
Good. I guess you have one more question in the chat. Does anyone have data on decreases in a readmission in their system? I guess with CCM, utilizing CCM.
So we did do a resident project in the past for our chronic care management patients, and we did see that not only were we able to reimburse and it almost equated to a pharmacist's salary, but we also were able to improve outcomes. And some of those were blood pressure and diabetes, but we also looked at acute healthcare utilization, and we were able to reduce acute healthcare utilization.
See a message: if patients are referred to the pharmacist, does the pharmacist then follow them every month, or just when consulted? There is a person who, again, if you're using vendors or not, who's supposed to be kind of the care coordinator, and that does not need to be the physician. That can be the pharmacist, that can be a nurse, that can really realistically be anyone on the team. So it really depends how you set things up. So for instance, our system is set for just the pharmacist to basically do everything. So we are the ones who are doing all the calls, checking everything, doing all the orders, etc. So we're not necessarily consulted, but you could have a system where, yeah, the pharmacist is just consulted as needed. It really just depends how you set it up.
Yeah, so our system, as I mentioned earlier in the presentation, we did set it up so that pharmacists are consulted on patients that would benefit from pharmacy services, and it's dependent on the pharmacist's clinical judgment, right? So if we see a patient for diabetes and they're not as complex, we may see them once a month, but let's say we're starting them on insulin brand new, or they're having, hypoglycemia, things like that. We could talk to the patient, several times in the month, and all those minutes add up. And then we tend to follow the patient until they meet their goal. So once they meet their A1C goal, we will typically defer them back to their primary care provider. Of course, we have some patients that they don't want to be deferred back, and they still want those calls, and they still want their pharmacist on their care team.
The nice thing too is you have the care plan for these patients has to have their goal of, like, for diabetes, A1C less than 7%, blood pressure less than 140/90 or 130/80. These are chronic conditions. They will not always be meeting those things. You are trying to meet those goals on a long-term basis, so you can reasonably justify seeing the patient monthly, even if they are controlled. Because the whole point is to have constant touches on the patient to say, okay, how are you doing? How are you doing? How are you doing? 3 visits in a row where they're doing absolutely fine, but then one you catch where, oh, your numbers are skyrocketing. What's going on there? That's what the whole point of this is.
Yep. To try to catch it before, instead of the patient getting so uncontrolled, they end up in the hospital, right? Like we were managing through them throughout the continuum, and noticing when their blood pressure starts getting elevated, when they have gotten frustrated with their diabetes and not being adherent. We catch that quicker than them being hospitalized. And there's been many times that we defer a patient back to their primary care or back to their care manager for chronic care management because they met their goals, and they come back because they've fallen off the wagon again and they need help. So ideally we would just continue to follow them, but we're trying to leverage our care managers and let them practice at the top of their license where they can catch where these patients are not meeting their goals again, and then defer them back to pharmacy where we can then do the management.
So I guess I have a question, Amanda, for your pharmacist in clinic. How much time in the week are they allotted to do like these CCM consults versus, other pharmacist services that you guys have?
To be honest, we don't have a set time. We've kind of given the pharmacist the ability to build their own schedule because we have some pharmacists that cover clinics that have a ton of chronic care management patients, right? Like we have some clinics that are really heavily Medicare patient populations where other clinics are heavily Medicaid patient populations. So those pharmacists are given the liberty to know their schedule and what they need to, how much time they need to dedicate to chronic care management versus face-to-face visits versus population health initiatives, things like that. Because every pharmacist patient population is a little bit different.
And adding on to that, Amanda, we all have some remote days. So it's nice we have pop health days that we add on to, and then we also have shared lists. So pharmacists who are working on their pop health days remotely can look at the shared list and see, hey, is there a med rec that needs to be done, etc. So like Amanda said, there's no set amount of hours.
Yeah, and I didn't really mention the shared list, but we do have a shared list amongst all pharmacists where we tend to put our chronic care management patients that just need a medication reconciliation versus continued medication management. So if you get a referral as a pharmacist and it's for diabetes, then you're going to continue to follow that patient. But if you get a referral for medication management and you don't have the time, we put it on a shared list, and the pharmacist that is assigned to population health remote monitoring that day can say, hey, I have some extra time. I'm going to pick up that patient, even though it's not technically in my pod that I cover.
I'll emphasize, I think it's my third or fourth slide has the CMS booklet for this. It is a really good fact sheet, tells you how to do it. It's really, there's a lot of ways you can make it work for your organization. Depends on who you want to involve. If you want it to be all pharmacy all over it, or if you want to make it a global effort from every clinical person in your sites. There's no right way to do it. The only purpose is to help patients.